We're going to be right up to about 8 o'clock. All right, 1 second. Where did you go? All right, let's look somewhere else. So we're going to be teaching this week over at Cahoots, and I'm going to add a little bit more to the normal way I talk over the Cahoots, but a little bit more to try to get you to think about what do these things mean. All right, anybody trying to get on, or we're just going to go? Who's going to win today? Yeah, I know, Brian, you always like to win. First question, growth hormone is administered by what root? Well, we're talking about the endocrine system, and this is the pituitary gland. And the pituitary gland secretes a growth hormone, which can let you grow. But we know some children don't have enough, or they're just really tiny. This is something that the parents really have to really do some due diligence with. It is a subcutaneous injection on these children. And it's either once a day, once a week. It depends on the type and the physician that you're working with. And we'll continue to give a growth hormone until they stop growing less than 1 inch a year. And then we say, okay, that's enough. It's about as tall as we're going to get. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. Like, wow, what a word. Inappropriate means if something's wrong, and it's antidiuretic, means against urinating, which means not urinating. It is causing you not to urinate. Makes sense when I put it that way. And when you're not urinating, you know, what are we going to have to do for that child? Well, we got to make sure we get that urinating going, but we only know that by intake output and daily weights, right? Because weights can show fluid loss along with the intake output. So we have diabetes insipidus, too much urine. And then we have the SIADH, which is retaining, holding on to fluids. There's 2 different ends of the rainbow there. Which of the following are signs of the syndrome of inappropriate antidiuretic hormone? What do you see? Remember, antidiuretic, against urinating. You know, diuresis, diuretic makes you urinate. Anti means against urinating. So you're not going to have urinary output or extremely decreased. Has nothing to do with specific gravity, glucose, or any of that stuff.
I will know I accidentally clicked that one. That was my mistake. I was right.
What is important to cover when teaching the family about polypropyl? It's also known as PTU. It is used for hyperthyroidism. It blocks the thyroid hormone from producing, but there's a really interesting side effect for this that we need to tell our families. Well, it does cause a patient to be leukopenic, which means your white cells just are not doing what they should do, and they're going to be decreased. So you don't have white cells, you're going to get infections, get fevers, sore throats, and not talk like your professor. An initial sign of diabetes insipidus is well, diabetes insipidus, again, comes from the pituitary gland. We have the SIADH, which blocks urine. Diabetes insipidus is I am thirsty and I'm urinating. So polydipsia, polyuria has nothing to do with not eating right. Polyphagia has nothing to do with perspiring. Blood sugars has only to do with urine output. SIADH, diabetes insipidus, only has to do with urine output. Too much or not at all. A multi. What are the clinical manifestations of juvenile hypothyroidism? Now, when you talk about hypothyroidism, does it really matter if you're an adult or a child? You're still going to have the same symptoms. But children, there's one thing that the thyroid gland does that we don't need in adults, and that has to do with growing. Okay, thyroid gland is good for an infant for cognition. Also, it has to do with growing the right way. So dry skin, thinning hair, it's not going to be weight loss. It's more of a weight gain. Constipation, these are things that you will see, adult or child, but decreased growth is specific to your child. A child's had a simple febrile seizure. What education would you provide to the parents? Now, febrile seizures is something that happens in some children, not all children, and they usually will grow out of it. You know, when we talk about seizures, it doesn't matter if you're tonic-clonic, febrile seizure. In seizures, our goal is all we can do is keep them safe. Put the head of the bed down, turn them on their side, remove any objects that could hurt them, pat the side rails if you can, and that's it. We really can't do much more. Febrile seizures are usually from your 6 months to 6 years, about that you start to see them. My oldest grandson actually had one febrile seizure and never had any more. But, you know, the mom to this day still takes temperatures 3 times a day. It just became something she does, like brushing your teeth, because it was so scary. But it's the rate of rise, how you went from no fever to a big fever in 20 minutes. So 98.6 to 102. It said the brain sparks and you have a seizure. Not all kids do it. Some kids do. What type of seizure is when the body's jerking, you're foaming at the mouth, and the child is rendered unconscious? Now, these are the children who are postictal, or they can't remember what's going on. Sometimes children, if they are cognitively aware, can tell you they're having this feeling, this aura before it happens. And these are your tonic-clonic, absolute tonic-clonic. Absent is when your eye just twitches. It's nothing more than that. And a psychoseizure, I have no clue. And it's not atonic, it'd be tonic-clonic. It's just a different word. After a fall, what would be considered a neurological emergency? I'm talking falling off of a ladder to concrete, falling off of a of a roof onto the ground, onto the sidewalk or to the driveway. You know, remember, this is emergency would mean there's pressure building up in the head. How would you know it? And that's looking at the pupils. Whenever you see a pupil that's all big and black and round and does not respond to light, the pressure in that brain is large, like too much. And if we don't take that pressure away, this child could have some permanent neurological injuries. Usually they'll put a brain drain in or do surgery or evacuate the hematoma, but that fixed, and it's usually one, not both eyes. With a patient with a head injury, the signs of increased intracranial pressure include increased. So you already know there's pressure there, but it's getting worse. How would you know that?
Oh, that's you want to play?
Whenever you see that change in the level of consciousness, you know, you'll get kids come in and they'll be in a sports accident and I've seen kids go headfirst into the base and hit the knee of the defender and be knocked out. And they come in and they start asking, where am I? Did we win the game? Did we win the game? And it becomes to the point where you can't even arouse them. We know that that's increased intracranial pressure, and we look for stuff like that. What notable sign may indicate increased intracranial pressure in the infant? Well, you know, the infant, are they alert? Are they sleeping? You know, it's hard to tell. But there's two, well, actually three big ones that you'll see. And one is not listed. And one is completely wrong. So bulging fontanelle when a wide awake and not crying, just laying there. You know, that's pressure coming out the fontanelle. Many infants bulge their fontanelle when they're crying. So it has nothing to do with increased intracranial pressure. The other thing is this high-pitched cry. If you work in infants and you hear a child that has neuro problems like increased pressure, you'll never forget it. It's like nails on a chalkboard. It's very high pitched sort of cry. It's not normal. And then you'll see the scalp veins in their head start to bulge on them. And those are things that you would see, that fontanelle, when they're just laying there, is bulging. Those scalp veins are popping out, and that cry, you know that there's something going on. All of the following increase intracranial pressure except what? So anytime you touch a child, it can increase it, but tachycardia, the sort of heart rate does not affect pressure at all. You know, you turn them, you suction them, they're coughing, all of that stuff will bring pressure up, but not the heart rate. Which of the following signs and symptoms are more common in children than adults following a head injury? Ever have your kid fall on the floor and have a lump on the head like this one? It's scary. But adults, they're not going to be the ones that vomit. Very rarely does an adult vomit. They usually have the headache that gets worse and then the altered mental status, but they really don't vomit. So adults, there's other signs and symptoms you need to look at. Children, they'll be vomiting. What medication can be used for a child with cerebral edema due to a fall? What do we use for the brain, for fluid, pressure in the brain? What is the med we use? So when we talk about a diuretic, something that can relieve that edema, is mannitol. Remember, mannitol is all brain. It's also used with some toxic chemicals or sometimes with renal failure, but mannitol is for the brain. And when we use it, it works really quick, which is what we want to do because we want to protect and save the brain from damage. Rey syndrome, what is it? So Ray's syndrome has to do with aspirin and taking aspirin. And the reason why there could be issues is because there's a metabolic problem, and it's mostly in your children. We only use aspirin rarely. Sometimes in some cardiac kids, we'll use it. But also when you talk about Kawasaki, those are it. We really don't like to use aspirin for children. Febrile seizures usually occur in what? How old are they? And that's between 6 months and 6 years. They usually will grow out of it. And I think that's the one thing that parents look forward to, because once they see their child having a febrile seizure, it's scary. But to know they'll grow out of it is a little bit of relief. Childhood hypopituitarism results in which condition? Remember, the pituitary has to do with fluid balances. And urination. It all has to do with growth and using growth hormones. You have anterior pituitary and posterior pituitary. So when you're talking hypopituitarism, in this case, it's that the growth. So they could be because dwarf because of low pituitary output. How would you describe precocious puberty? You know, all children go through puberty of some sort, some way, but precocious can be confusing. And it's just reaching puberty too early. You know, I went back and was doing research and looking at pictures, and there was 5 and 6-year-old girls that had breasts. There are boys the same age with beards, you know, and it's because they go through puberty too quickly. Now, we can give medicines. We can delay it until that point where they should be going through puberty normally. Signs of hypothyroidism. It's a great slide. It shows you everything there, doesn't it? And remember, the only difference between the adults and children, it has to do with growth. You need thyroid hormone for growth. And for the infants, it also will affect cognition if we don't replace those thyroid hormones. A multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? I mean, can't you even say this is important for all age children and adults, something that we should be monitoring? Especially if we know they have thyroid problems. And it's thyroxine and TSH. Remember, thyroid has to do with growing okay, but it's not the growth hormone. That's in your pituitary gland. Cortisol is your adrenal gland, so it's nothing to do with those. T4, TSH, when the T4 is low, the TSH is high. When the T4 is low, it's opposite. So when one's up, one's down, and that's the way that you do see it. But it is important to monitor so we can give medication so that child gets what they need for cognition and for growing the proper way also. How can you monitor a child with hypo or hyperthyroidism? So we know that it has to do with the growth. So height and weight, that's going to tell me, is the child getting enough of their hormones? What acid-base alteration would you use in a diabetic child with Kussmaul respiration? Well, when you talk Kussmaul respiration, you're in diabetic acidosis. It's a metabolic acidosis. So your body wants to turn it around. So it's telling you that Kussmaul respirations, what does it do? It's opposite from metabolic. So it's also, we're doing opposite of what you have. If you're in acidosis, it's going to produce alkalosis. Now, the reason why you need to know this, there are 4 questions on your essay about acid bases. So explain it again. Metabolic acidosis caused by DKA, child starts Kussmaul respirations. The body's trying to fight against this metabolic acidosis. So then the lungs start working and trying to produce alkalosis to balance out this DKA, okay? So it's opposite, and that's what the body does. A multi-select. What would a child with Cushing's syndrome look like? Okay, now we're into some adrenal stuff. So Cushing's syndrome, you're going to have that pendulous abdomen and striae, going to have hair. Children with hair on their chins, it's not normal, but they have thin little extremities and they got those ruddy cheeks, okay? And they're going to have weight gain, not weight loss. Seizures in children most often are the result of what? So it's when you've gone from no temperature to a temperature in 15, 20 minutes. So it's that abrupt rise in body temperature. And the brain sparks and says, I don't like that. And you have a seizure. A multi-select. You walk into a child's room with a fever of 104.6 and you see them having a seizure. What can you do to protect this child? What can you do for them? So the only thing you're not going to do is give some cold water or put them in ice, give them a shower. No, that can actually spark more seizures. You're just going to protect them. It's all about safety. Check in the bed for objects that are hard and sharp that could hurt them. Side rails should be up and pad them if we have something there. And of course, turning to the side in case they vomit so that they can have an airway that's open if you can without hurting them. An autoimmune disease of the thyroid gland. This is usually adolescents and it's more girls than boys. My daughter-in-law has this. And the big thing about it is it's autoimmune. You can't remove it. It's something that you need constant regulation of your thyroid hormones that she takes and constantly looking at those levels because any autoimmune disease is affected by stress. So you're going to constantly need to be changing dosagings. And it's called Hashimoto's. And it's something you just have to live with, something that you need checked on regularly. Addison's disease. So we had Cushing's disease is too much, right? It's another adrenal. We're talking about cortisol. Remember, there's always one too much and one too little. So which one is which? And that's what you need to remember, you know, for MedSurg 2 and also for peds. So when you're talking about an adrenal issue, not enough secretion of cortisol and aldosterone. And that's what the adrenal gland does, okay? A multi-select. A ventricular peritoneal shunt. This is a tube that goes from inside the body into the ventricle. It goes behind the ear, comes down the front of the body into the peritoneum, and it drains cerebral spinal fluid. These are used in those children who have too much fluid in their heads called hydrocephalus. These pumps we should never touch. There's like this little ball behind the ear. Only a neurosurgeon should touch those. As a nurse, we'll measure head circumference, abdominal circumference, and that's about all we'll do. If they're having symptoms of headache and vomiting, those are usually something to do with the shunt, and they'll go and they'll find out, is the shunt working properly? Because this is something that's going to need replacement periodically as a child grows. A common sign of Graves' disease includes blank or protrusion of the eyes. This is in hyperthyroidism. It's called exophthalmos. There's a new commercial on TV all about that, putting drops in, and this lady wears sunglasses and she keeps taking off glasses and there's more glasses underneath. I just laugh. I think it's a funny commercial. Multi-select. What are signs of hyperparathyroidism? Now, the parathyroid is completely different than a thyroid. They regulate different things. Well, number one, what does a parathyroid gland do? What does it regulate in the body? And the answer, it regulates calcium. Now, I want you to remember, in calcium, magnesium, when you hear about that and side effects of too much, too little, remember it has to do with muscle tetany and spasms, in the muscles. So if I have too much, I'm not going to feel well at all. I'm going to be confused. I'm nauseous. I'm vomiting. I'm going to be hypercalcemia, and I'm not going to feel well at all. Hyperthyroidism, you're going to have the parathyroid removed. A multi-select. Hypoparathyroidism has the symptoms of tetanic muscle contractions and, again, parathyroid talks about calcium. Calcium, what do we know are signs of low calcium in the body? It's all about muscles, right? So the muscle weakness, tetany, and as I said, low calcium levels. Vitamin D has to do with joints and it's not the muscles, so it has no correlation. What does the parathyroid hormone do? You know this one now for sure. It regulates calcium. Calcium. Parathyroid, all it works with is calcium. If you take it out because of hyperparathyroidism, you're going to have a replacement. And it could mean actually taking 1 Tums a day because it has calcium. I mean, as simple as that. Which of the following might be a cause of an adrenal crisis, Addisonian crisis? So when we are on steroids, we are always tapered off slowly. When you talk about Medrol dose pack, it goes, I believe, 7 pills down to 1. It's because we have to come off slowly. If not, our adrenal gland is not happy and you'll go into a crisis. A multi-select. A cardinal sign of diabetes insipidus. Posterior pituitary gland. Remember, you have SIADH and you have diabetes insipidus. One is too much and one is too little. And diabetes insipidus is 2 Ps, not 3. Polyphagia has to do with not able to eat or chew properly. It has nothing to do with the regulation of fluid balance. So polyuria, polydipsia, okay? And it's an increase of urinary output. You're urinating, urinating, urinating. How are we going to monitor? Priority nursing care. Intake, output, daily weights. Limit fluids, limit salt. A multi-select. A congenital hypoplasia parent teaching should include. This is adrenal hypoplasia. The adrenal glands not only produce steroids, cortisol, it also has to do with sex hormones, right? So if we're not getting enough sex hormones, infants are born that we don't know if they're a boy or a girl. I've seen one in my career, and actually the very beginning of working in the newborn ICU. And this girl had like very fat labia that could have been testicles, had a vagina, and had a prominent clitoris, which looked like a penis. So what they needed to do is to assign, is it a boy or girl? And what they did is they did some hormone testings and ultrasounds to see what body parts they had that might work the best for the child. But this child will never be able to have children. And because it's an adrenal hypoplasia, means adrenal gland is not giving the body cortisol and aldosterone, they'll be on replacements for life. What causes type 1 diabetes? 36 candy bars. So you think of diabetes, you think of insulin, and you think of the pancreas. And the pancreas, islets of Langerhans, they're not, or they can't, or they've been destroyed, don't have enough to produce insulin to take care of the sugar and digest it. And that causes type 1 diabetes. So then the body says, I'm hungry because the sugar is not now being digested. And that's when it goes for protein. What statement about a pheochromocytoma is correct? Again, this is an adrenal tumor. Something that's actually very hard to diagnose. These children and adults, all of a sudden they'll have like these periods of elevated heart rate, blood pressure goes up, chest tightness, maybe dizziness, and it's intermittent. And, you know, hopefully you'll catch it on a 24-hour Holter monitor or something. But this is something that this little tumor produces catecholamines, which is like giving epi. You know, what does epi do? Elevated heart rate, elevated blood pressure. It's a catecholamine. It's a sympathetic type of drug. So everything speeds up. And as a nurse, and if we know they have this pheochromocytoma, we need to be monitoring what? Well, heart rate and blood pressure, right? A multi-select. What action should the nurse implement in the care of this patient with a pheochromocytoma? It's a catecholamine producing tumor on the adrenal gland. And treatment is to remove it. So we're going to be monitoring for hypertension and heart rate. Adrenal gland has nothing to do with blood sugars, and it has nothing to do with weight gain. Actually, if my heart rate kept going up and down, probably it'd be weight loss, if anything, but not really. A multi-select. Nursing care of the unconscious child should include what? So we're going to do neuro checks on an unconscious child, which is the neuroscience, vital signs, and of course, strict I&O. I mean, if you're unconscious, usually there's some pressure in the brain. We don't want to add extra fluid in the brain. So making sure that our intakes are not more than our outputs is very important. I mean, pain control, we can, but more of the other stuff is what we really are more priority. Symptoms of diabetic ketoacidosis are so diabetic has no insulin, it's not eating sugar. The body's hungry, says, okay, where else can I go to eat? I'm hungry. All right, let's go get some proteins. Proteins break down and it produces ketones. The sugar's still in the body, so I breathe this fruity breath. Now let me explain what it smells like. If you took a peach and you put it in a Tupperware dish and you put it in the refrigerator for a month, take it out and open it, and that fruity, rotten smell is exactly what you would smell on DKA. And I'm not exaggerating, it is exactly that. Very distinctive. Multi-select. An adolescent with a BMI above 95% has been urinating a lot. What tests can you anticipate? What do you think the doctor's going to order for this adolescent? So we're going to do a urine because they're urinating a lot. But the big thing here that I was trying to get the point of, you have a child who's larger and urinating a lot, is probably diabetes. So hemoglobin A1C is that. Will we be looking at electrolytes? Maybe, but the first things is the urinalysis, but most important, the hemoglobin A1C. Diabetic ketoacidosis is caused by what? So when you are diabetic DKA, you have nothing that can eat sugar. So you have no insulin. So the body goes somewhere else to eat, and that's the proteins. So you have elevated blood sugars and you have ketones spilled from the digestion of proteins. So that's why you have diabetic ketoacidosis. Sugar's still there, but we're burning protein and ketones is the byproduct. A multi-select. A child with blood sugar of greater than 600 large ketones in the urine. What is your priority intervention? What do you need to do first on this child? What is your priority? Remember, these children usually have blood sugars, great, but it's the pH is usually 7 and lower. And when you get these low pHs, you can burn their brains, and you don't want to do that. So we need to get that blood sugar down quick. So number one, you start an IV with a bolus of normal saline. You need to get fluid into these children so we can, take the ketones and get them, out of the body. Also, regular insulin can be given IV, and it's a very slow insulin drip monitoring their blood sugars as we go. And then to follow, we'll be monitoring the electrolytes, but you can't do anything until you get that blood sugar down. A diabetic child complains of feeling jittery and the blood sugar is 45. What's the best treatment for this child? Give them a glass of orange juice, give them a glass of milk. Both of them work very well. If you can, turkey sandwich would be good too. Your patient has experienced a head injury. What would most concern you? Remember, your head injuries, You got fluid, maybe pressure building up in the head. What would show you that the pressure is building? Besides increased vomiting, increased headaches, decreasing, your mental. But it's that decreased urine output because it's squishing against that pituitary gland too, right? So then what are we going to give if there's fluid in there? Mannitol. A multi-select. How do you detect ketoacidosis, diabetic ketoacidosis? Now, if anybody has problems with diabetes and understanding it and you need help, please come to me and I'll talk to you and I'll make it very simplistic for you. So we're going to have elevated blood sugars, we're going to have ketones, and we're going to have 4+ glucose in the urine. Absolutely, that's what you see. And then, of course, you do a ABG and you're going to be acidotic. A multi-select. What would alert you that a child's head injury is deteriorating? And the key word is, how do you know they're deteriorating? It's getting worse. That means they're getting restless. They're difficult to arouse, right? They're already going to have a headache and be a little confused. But if it gets that point where difficult to arouse and restless, now you know it's getting worse. A child's been diagnosed with bacterial meningitis. What is a nursing priority of care? What are you going to do for this kid? How are you going to get this kid home where this child needs to be? What is your priority? And it's antibiotics, number one, antibiotics. Fight the infection. Those meninges hurt, they're inflamed with a bacteria, fix them. What is the primary cause of injury associated with submersion? Drowning. What do we worry about with drowning? Primary cause of injury. I live in South Florida. I've seen quite a few drownings, actually. I've seen good outcomes and I've seen not so good outcomes. And it's all because the fluid gets filled up in the lungs and they can't exchange oxygen. So it's that hypoxemia, which is the biggest injury. Yeah, they get pneumonia and all that stuff, but it's hypoxemia. And last question, multi-select. Which CSF lab results correlates with bacterial meningitis diagnosis? Well, number one, I'm telling you that grossly cloudy cerebral spinal fluid is definitely bacterial. But when those results come back, there's two things I look at to see if it's there. I mean, I want to see that it'll be an elevated white count, not decreased, elevated. But bacteria loves sugar, so it eats it up and it leaves protein alone, so they're elevated. So when I see that, I'm, okay, what antibiotic do you want, doc? I want to start it right now. Priority, right? Good job, guys. We made it. Number 3, T. Hi, T. Number 2, Tiff. Good job, Tiffany. You were intently thinking. I saw you. And Abby, number 1, good job. Number 4, he did it, Big B, and Ms. Little. Good job, guys. Want you to sign your attendance attestations. Don't forget about it. Remember, if you didn't sign it, you didn't do it. I try to go through and let you know to give you a heads up. So remember, if you want your grades, let me know. Ms. Little, I will send it to you shortly. I saw you that earlier. Anybody else? Thank you for a great class, a great exam.